ആദ്യം നന്ദിയേക്കും തന്നെ. ആമേൻ. ഞങ്ങളെ സ്നേഹിക്കുന്ന ഞങ്ങളുടെ സ്വർഗസ്ഥ പിതാവാം ദൈവമേ, ഈ നവംബർ മാസത്തിൻ്റെ ആദ്യത്തെ വ്യാഴാഴ്ച ദിവസത്തിനായി നന്ദി. ഈ വർഷം മുഴുവനും ഓരോ വ്യാഴാഴ്ചയും ഇതുപോലെയുള്ള ക്വസ്റ്റിൽ ഞങ്ങൾക്ക് പങ്കെടുക്കുവാൻ, പുതിയ കാര്യങ്ങളെ ഗ്രഹിക്കുവാൻ ദൈവം ഞങ്ങളെ സഹായിച്ചു. നന്ദി. ഇന്ന് ഡോക്ടർ നിതിൻ തോമസിന് വേണ്ടി പ്രാർത്ഥിക്കുന്നു. ഞങ്ങളോട് പറയുന്ന കാര്യങ്ങൾ അഥവാ ഞങ്ങൾ കേൾക്കുന്ന കാര്യങ്ങൾ ഗ്രഹിപ്പാനും ദൈവം ഞങ്ങൾക്ക് ചെയ്ത ഉപകാരങ്ങൾ ഒരു പ്രാവശ്യം കൂടെ ഓർത്ത് നന്ദി പറയുവാനും വീണ്ടും അടുത്ത സ്റ്റെപ്പിലേക്ക് ഞങ്ങൾ കയറി മുൻപോട്ട് പോകുന്നവരായി തീരുവാനും അത് മറ്റുള്ളവർക്കൊരു അനുഗ്രഹമായി തീരുവാനും ഞങ്ങളുടെ ഹോസ്പിറ്റലിനെയും ഞങ്ങളുടെ മറ്റ് സഹോദരങ്ങളെയും അനുഗ്രഹിക്കുവാനും ദൈവം സഹായിക്കണമേ. അങ്ങനെ ഇവിടെ നിന്ന് കടന്നു വന്നവർ ഇനി വരുവാൻ പോകുന്ന എല്ലാവരെയും അനുഗ്രഹിച്ചാട്ടെ. പ്രാർത്ഥന കേട്ടതിനായി സ്തോത്രം. യേശു ക്രിസ്തുവിൻ്റെ വിലയേറിയ നാമത്തിൽ തന്നെ. ആമേൻ. പ്ലീസ് ബി സീറ്റഡ്.
Good morning and welcome to this quest. Especially want to thank our director for being here, and this subject is in some way an emblem or a standing for what has happened in the Department of Orthopedics since its inception here in our institute, the year 2014. I think the very first doctor who joined the institute was Dr. Joji Joshua. And so we've been part and parcel of this from the very first step, the very first go, as it were. And when we hear Dr. Nitin's presentation, it is the journey of the department, it is the journey of this institute, and it is pointed to some place in the future. And even though we have come a fair way, there is a huge amount more to go before we can say we have reached the point. This presentation is about technology changing the way we see things, we approach things, and we do things. But technology is never the only thing that happens. Technology has to be taken in hand, has to be molded, guided, and used in the most appropriate way. And therefore, there is always a need for the person who is using the technology to do it with dedication, commitment, and wisdom. So I think in some ways Nitin is also someone who embodies many of these qualities, and Dr. Nitin will be taking us through this journey of the Department of Orthopedics, but it's also in some way his own personal journey. So I stand here as a privileged person, having been part of this journey, and this is what medicine is going to be in the future. So we're going to see how technology plays out in the field of medicine, and perhaps how inevitable it is that we need to take hold of the advances in science, the advances in technology, and keep on board the various things that are happening without losing sight of our goal, that we still need to meet the patient with the compassion of Christ, and for the patient's sake we wish to do the best for him. So without further ado, handing over to Dr. Nitin for the presentation.
Thank you, sir. Today the topic is a bit different. That is our gratitude, the gratitude of Department of Orthopedics. In every step, the story of 3,500 knees and the many hearts that we touched upon. Every knee replaced is a story of faith, teamwork, and transformation. So before we start telling about our surgical techniques, our milestones, let us take a step back and think about what we are trying to preserve here. So a knee, a simple joint, a complex miracle. It bears our weight, absorbs our impact, bends with grace, yet it asks for nothing but the ability to move without pain. The most trusted joint in every human step. Having said that, let's move on to the simple anatomy of the knee. So it is formed by the tibia bone, the fibula, which is a non-articulating bone. Then you have the lateral meniscus and the medial meniscus, which forms the cushion in between the knee joint. Then you have the medial collateral ligament, which gives the medial stability, the lateral collateral ligament, the lateral stability, the anterior cruciate ligament, which gives the anterior stability, the posterior cruciate ligament, which gives the posterior stability. Along with that, the articulate cartilage, which helps in the smooth motion of the knee, the femur bone, and the patella forms the bony anatomy of the knee. Bones are not enough. We need to move the joint. So we have the muscular anatomy, where the extensor mechanism consists of the patella tendon, and the quadriceps together forms the extensor mechanism, which helps in the extension of the knee, which helps you to get up from a chair. Then you have the hamstring muscles, which is getting attached to the posterior part of the tibia, which helps in the flexion of the knee. Along with that, you have the tibial nerve and the peroneal nerve, which is supplying these muscles, the popliteal artery and veins, the synovium and capsule together forms the knee joint. So as you know, the knee is just a hinge joint. Is it really a hinge joint? No, it's not. So bending or the flexion, it means that the femur is rolling back on the tibia with a slight rotation of the tibia. And when it extends, the final part, the tibia rotate outwards to a process known as screw home mechanism, which will help you to stabilize the knee. So it's a complex motion that is happening there. Everyone has a concept of total knee replacement. So let me tell you the brief principles of how we do a total knee replacement. So it is not just cutting the bone and replacing with the metallic implants. So it is a resurfacing technique where the damaged ends of the bone are replaced with a smooth metal or a plastic cap. So how do you do that? You make an incision in the center, move away the patella, take specific cuts to remove the degenerated or the arthritic part. We can put the implant with the help of a cement or a glue and a spacer in between. This forms your knee replacement. Sometimes we remove the part of the patella and replace it with a plastic cap. So that is called a patella replacement. So this together forms the total knee replacement that we do. A brief history about the evolution of knee replacement. It started as a high failure attempt in 19th century to a highly successful, technologically advanced procedure as of today. The initial thoughts were about the implant. How do you recreate the movement of the knee? Once the implants were perfected, then the idea changed to how do we minimize the wear that is happening in between the knee joint. Then comes the precision, where there is patient-specific jigs, which is used to cut a specific part of the bone. Then comes the integration of the navigation and computer-assisted surgeries, and finally the robotic era. So the evolution happens. The first resection arthroplasty, that is just removal of the damaged part, was done in 1861 by Dr. Ferguson, followed by interposition arthroplasty, where the damaged parts are removed and a soft tissue or a different material is put in between the bones, by Dr. Verneuil in 1863. Then comes the hemiarthroplasty, where the part of the joint is replaced in 1940. And the precursor of the current evolution, the total knee replacement, the hinge processes started in 1958 by Valdius. So this process doesn't look like a knee joint. So the thoughts were how to make it look like a normal knee. So making the implant more knee shaped. It started in 1970 by Yamamoto knee and Gunston knee in 1970s. Then the thought process were, how do we preserve all these ligaments that I've talked about earlier? How do you preserve the normal anatomy? So the first attempt at preserving the cruciate ligaments were done by geomedic knee by Dr. Mark Coventry in 1971. And the precursor of what we are seeing today, the evolution of knee, fine-tuning, happened in 1971 with a duocondylar or a total condylar design by Dr. Chittaranjan Ravanath, Alan Inglis, John Insall, and Peter Walker. So this forms the basis of what we use right now. So as of now, our current implants include these implants from multinational companies and Indian companies. So once the implants are perfected, the thoughts turn to how do you prevent the wear that is happening in between the poly. So various thoughts regarding a mobile bearing and a fixed bearing came in, where the polyethylene that we put inside moves along with the knee joint, reducing a contact stress. So initial polyethylene had a wear of about 0.05 to 0.1 millimeter per year. The minimum thickness of the poly that we put is 8 millimeter. Then comes the cross-linked high molecular weight polyethylene, which reduces the wear to up to 0.01 per year, and vitamin E impregnated, which is having a better potential and has less free radical formation and has oxidation resistance, has come into picture. The materials, most often our patients are asking us, which material do we use? So the most common material that we use for our replacement, roughly about 99%, is cobalt chromium with titanium and a polyethylene insert. So we have newer materials like the delta ceramic, which is having a very less friction coefficient, but the problem is it's brittle. Then you have the coatings that we usually use, that is the oxenium or the zirconium alloy, which reduces the friction between the joints to a very high rate. So depending upon which implants you choose, the cost also varies. Then comes the evolution of techniques. Once you are perfected with your implant design, your polyethylene wear, then the technique turns towards how do you do it. So as you know, all the varus knees are not varus knees, and all the valgus knees are not the same. Everything is different. So then comes the coronal plane alignment classification techniques. Add-ons are like hinged, the high flexion knee, where you are able to do a flexion of more than 140 degrees. Patient-specific knees, where the patient's CT is taken and an implant is made for that particular patient. Basically, the knee replacement can be classified into 4 types depending on the amount of the functionality of the implants that you have. That is the first one, the cruciate retaining, where you retain the posterior cruciate ligament. Then if the posterior cruciate ligament is not functioning, then you have the option of a posterior stabilized knee. Then if your lateral choroidal ligaments are mildly functioning, then you can probably go for a constrained knee. Then if your ligaments are not there, then probably you will have to go for a hinged knee, where the entire mechanism of the knee is taken care by the implant itself. So as the constraints increase, the life of the implants decrease. Then comes the era of precision and accuracy. So computer assisted surgeries, the patient specific instrumentation come into picture. And then finally the robotic system. So robotic systems can be classified into 3 types, where the first 2 pictures are the ones which is completely autonomous. You feed the data into the system, you tell the system you cut this, this and that, and the system will do it by itself. The second thing is the semi-autonomous ones, where the system will keep the robotic arm in place so that you can take the cut. And the third one that we use now is a completely surgeon specific one, where the surgeon has the complete control of the instruments, and it's a very small instrument which can be integrated into our system. Then comes the advancement of unicondylar knee replacement. So it is nothing but a procedure that replaces only one damaged component of the knee, and most often the medial side. So if you have the femoral condyle has the medial side and the lateral side. So most often we found that only the medial side or only the lateral side is having arthritic changes. So you don't have to replace the entire knee. So we have provisions for replacing only that particular component. It has its own advantages like faster recovery, less blood loss, lower wound complication. It preserves all the knee kinematics because all the ligaments should be intact, smaller incision and less post-operative pain. But there are specific indication for those cases. Like the age should be more than 50, BMI should be less than 30, and the deformities should be correctable and should be less than 10 degrees. Only one compartment should be involved and all the ligaments should be intact. So having said that, the final thing is basically quality control. So we do a lot of things. How do we understand whether we are doing it right? So in UK, we have something called the National Joint Registry, which enters all the total knee replacements that is done in UK. They have something called an orthopedic data evaluation panel, which will evaluate every single implant that is used in the country for a period of not less than 10 years. And they will give a number to that implant, a number and an alphabet. The number indicates the number of years the implant has been followed up, and the alphabet indicates whether it is a strong evidence for A and B for acceptable evidence. So any new joining will be allowed to do only a 10-year rated implant, and those who want to start off with a new implant, they have to register in the orthopedic data evaluation, which will be followed up for a period of 10 years. So this is in summary about what I've said, which started in 1890 by ivory knee by Gluck. It changed all the way to a total condylar design by 1971. Then comes the computer navigation in 1990s to 2000. The robotic surgery started in 2006. So what do a patient coming to an orthopedic department in Believers expect when they want to do a total knee replacement? So I will guide you through the journey that we usually follow. So when the patient comes to the orthopedic department, the ortho doctor will examine the patient, will take an X-ray, which is usually a standing knee X-ray, to find out the amount of damage that has happened to the knee. Then once the patient is decided for a total knee replacement, the patient will undergo a preoperative counseling, including a financial counseling. Then the preoperative workup is done, and finally the patient is seen by our anesthetist, and a PAC or a pre-anesthetic clinic, pre-anesthetic checkup will be done, and the patient will be deemed fit for surgery. So once the surgery date is finalized, the patient is asked to get admitted the previous day. The surgery and rehabilitation will take roughly about 3 to 5 days. Then the day before surgery, the patient will be having dressing and pre-discharge counseling, which includes what are the things that the patient can do and cannot do. So basically, the few things that we tell about our patient is whether they can turn to one side. Yes, they can turn to both sides. Whether they can climb stairs. Yes, they can climb stairs, but we don't actually advise them to climb stairs for exercises. Then physio, which is very, very important, where we will teach the patient home physio exercises, which include strengthening of your quadriceps and hamstring muscles. And usually the patient will be followed up in about 2 weeks' time for suture removal. And then 1.5 months, 3 months, 6 months, and yearly will be our follow-up. So this is what a patient expects when they do a total knee replacement in our hospital. So how are we able to do all these things? So this is not possible without our team, which is led by our head of the department, Dr. Vinu Matthew Cherian, our guide, mentor, and the associate director, Dr. Samuel Chittaranjan sir, our young and energetic, multi-talented Professor Dr. Joji Joshua, myself, Dr. Koshi George, who has the opportunity to be in 2 departments, heading the 2 departments, Dr. Thomas Angelos Correa, who is our hand surgeon, Dr. Subin Babu, who is our arthroscopy specialist, Dr. Danny K. Matthew, our pediatric specialist, Dr. Eknath, our upcoming hand surgeon, Dr. Mohsin, who is our upcoming arthroplasty surgeon, Dr. Rijul K. Raj, who is our limb reconstruction surgeon, Dr. Jobin John, who is our upcoming arthroscopy surgeon, and Dr. Arjun K., who is our spine surgeon. So without this team, this is not possible. We also like to include our postgraduates, who is a workforce of our department. We are missing one. So how does everything starts? So a vision that takes roots. The journey began with a single case done on 17th October 2015 by our first doctor to this hospital, Dr. Georgie Joshua Philippos, and our former HOD, Dr. Charles Abraham, doing the first total knee replacement. So what started as a humble beginning was driven by an unwavering vision to restore mobility with compassion, precision, and clinical excellence. So few of our milestones that we have achieved. The first 100 cases took about 2 years. Next 400 cases in about 2 years. Then comes the COVID era, where we have done 1,500 surgeries in about 3 years' time. And finally, in 2 years, we have done roughly about 2,000 cases. That is roughly 3,500 total knee replacements in about 10 years' time. So each milestone along this remarkable journey has been shaped by continuous innovation, dedicated learning, and unwavering teamwork. From mastering conventional approaches to embracing cutting-edge robotic technology, every step forward has been guided by our commitment to deliver exceptional patient outcome. So the robotic leap. Why did we embrace the future? The decision to adopt robotic surgery was driven by our commitment to precision and superior patient outcome. The robotic technology offers unprecedented accuracy in bone preparation, implant positioning, and soft tissue balancing. So a few advantages about robotic: the sub-millimeter precision, every degree, every millimeter matters. Accelerated recovery, where the patient experiences less soft tissue trauma and reduce pain and faster return to normal activities. And reproducible excellence, where standardized execution reduces variability and maintain consistent outcome across all cases. Through dedicated training and over 300 robotic procedures already done, Believers Church Medical College Hospital has emerged as a regional leader in robotic arthroplasty, setting benchmarks for quality and innovation. So how is that possible? Only with the help of a team. So our team consists of the anesthesia excellence, where they give patient-specific hypotensive anesthesia for the surgery, specialized protocols for pain management, especially in nerve blocks, where the nerve to the knee only is being blocked with a rapid recovery, post-operative patient care in the post-operative ward by our anesthesia team is excellent. The post-operative pain management assessment by our anesthesia team every day after the surgery is commendable. Then comes our OPD team, who is the first point of contact with our patients. The GR staff, nursing, SOC sisters, our physician assistant, Ms. Benshiga, and our therapist, Mr. Sambat, who take care of our patient when they come to the OPD. Our ward and nursing team, silent angels, who take care of our patients when they are in the hospital. The surgical team, the scrub nurses, CSST staff, technicians, and biomedical team who help us during our surgery and take care of our instruments. The physiotherapist, the rehabilitation experts who guides every patient's journey to a full mobility. Our dynamic secretary, Ms. Remia, who take care of us and coordinates all these programs in the department. So what does this team do? So with this team, we are able to achieve where most of the surgeons will think is impossible. Roughly doing a 14 TKRs in one day. So this is not about 14 TKRs. This is about the dedication, the thought process that went into every single person's mind before doing this. How the things are arranged. We didn't have even a single glitch. It went on very smoothly. So this is the team that helped it possible. So lessons that we learned from 3,500 knees. Patience over perfection. Each patient's anatomy and healing journey is unique. We have learned that listening carefully, adjusting our approaches, and allowing adequate time for recovery often matters more than pursuing technical perfection. The best outcome comes from personalized care, not standardizing it blindly. Complications as teachers. Every challenging case and unexpected complication has been a humbling teacher. These experiences have sharpened our clinical judgment, improved our protocols, and deepened our empathy. They remind us that continuous learning and honest reflections are essential to surgical excellence. faith, focus, and teamwork. Sustaining a high volume arthroplasty program requires more than just surgical skill. It demands unwavering faith in our mission, laser focus on quality and safety, and seamless teamwork across all the departments. Together, these pillars have enabled us to maintain excellence across 3,500 cases. So, few achievements that we have done. The first robotic replacement done on 18/4/2024. The soft launch of our robotic system on 26/9/2024. The first knee replacement patient robotic done on 3/10/2024, where the patient is walking in about the second day. Then you have the 50 cases in 3 months, 9/1/2025, 100 cases in about 6 months, 27/3/2025. The grand launch in 16/4/2025. The latest advancements is a unicondylar knee replacement, which we have done on 23/9/2025, where the patient is able to walk the very next day without any help of a walker. And we want to give the knowledge that we have learned to others. So we started the next generation training and center of excellence, where we developed a structured fellowship program to train future surgeons in advanced techniques, including robotic assisted surgeries. Our first candidate, Dr. Renju, who started with us from August 5th, 2025. Surgeon visitations, we had the privilege to have many surgeons who visit us for the for seeing the robotic surgeries. So the first one was done on 25/9/2025 from a surgeon from Trivandrum. The road ahead. So what are we planning to do in the next coming years? A joint registry and research, establishing a comprehensive institutional registry to track outcome, publish findings, and contribute to global arthroplasty knowledge, and a patient-centered innovation where implementing patient-reported outcome measures and expanding our program to serve even more patients with compassion and excellence. So our vision, every patient walks out with confidence, gratitude, and restored quality of life. So all this is not possible without the help of many people. So this time I take the opportunity to say our gratitude. This journey of 3,500 knee replacements would not have been possible without the vision of our hospital administration, our beloved manager, Father Sijo Pandapalil, our beloved director, Professor Dr. George Chandy Metitira, the wholehearted support of our medical superintendent, Dr. Jomsi George, our associate directors, CAO, Rosie ma'am, anesthesia team, OPD staff, ward staff, theatre staff, billing, pharmacy, store, insurance team, and all those involved in patient care. I also like to recognize the immense contribution from our dear Dr. Charles Abraham sir, which is our former HOD, who is instrumental in setting up our beautiful department, and Dr. James C. George for his surgical expertise. We also extend heartfelt gratitude to the families who supported us through long hours and challenging cases, and who understands that this work is both a calling and a privilege. Alone we perform surgeries, but together we transform life. So here is to the next 5,000. One step, one life, one blessing at a time. Thank you.
Thank you, Nitin. That was absolutely fantastic. It was lovely to see the journey of orthopedics over the years and to see our own journey. I remember the time when Sam first came and we had heard that there aren't patients who will come in to us for surgeries, and now you're showing us 3,500 knees itself done, a whole lot of other things. So, and each one of that is a quality surgery that has been done. I like that quote which says, alone we can do surgeries, but together we can transform lives. I just hope that all of us look at it that way. But Nitin, thank you very much. And to the gurus here, thank you so much for making this happen. And I just pray that this will be the story that everyone can say, each of our departments can present. So shall we just put our hands together and give a big...
There is nothing more really to do unless there is some questions anybody has, which Dr. Nitin will be happy to answer. Anybody wants to ask something? May not be some technical question, but any general question.
Dr. Nitin, wonderful presentation. What are the complications which you encountered so far after the surgeries?
So, as with any surgeries, there's a chance of infections, but luckily our infection rates are less than 0.5% probably if we take the total numbers. Then there is a lot of other intraoperative complications that can happen, which is when you're actually using sharp instruments, you can have injuries to the soft tissues, the ligaments, and all those stuff. But we have been fortunate enough to not have all these complications. Then the possibility of a post-operative complications like your pulmonary embolism, the DVT, and all those stuff. But fortunately, we also have not much of a case with complications. Infections are the most common complications that we actually encounter with this type of a replacement.
Okay.
Yes.
I think Madam is asking because she knows that we have had problems. It is true that we've had infections, but as Dr. Nitin said, the numbers are very low compared to what is internationally published. So we are better than the benchmarks that are there in the thing. But I think one of the things that has been plaguing us recently is the very unusual infection due to fungus, Candida parasilosis. It's a terrible, terrible disaster because it only appears very late, maybe after a year, after 2 years. Patient is fine till then and suddenly develops this thing. So we haven't yet overcome that problem. We don't know when it will strike. And of course, there are the 1 or 2 cases of pyogenic infections as well. But as he said, when you look at the numbers, we are quite all right to be within that. It's not possible to be 100% free of infections, even though we take all the precautions. That's one thing. And then we've had certain other smaller complications. So it's not that there is no complication. We've had maybe half a dozen cases of a DVT and about 1 or 2 PEs. To tell you that, yes, there are complications, but so far I don't think we've had any fatal outcomes. By God's grace, that has not happened. And we were able to overcome all these complications as they came up. So overall, it has been, as Nitin said, a wonderful journey and very, very good for our patients.
Yes, thank you, Nitin, for highlighting many things, and congratulations for reaching the milestone. I would like to know, have we had so-called the failures in 3,500 knees? And what has happened to the first patient so far? So that means what is the longevity of these replaced knees? And probably third one, what about the hip replacements? How is it proportional to the knee replacements?
Help with that. If you're asking about the very first case, I'll have to give it to the surgeon who did the very first one.
Just take a minute. I still visit her home. Her name is Omina from Kawalam. Now it's been 2015, 10 years now. She's been doing good. In fact, just to mention, that was the first knee that I done in this hospital, and then her sister was actually the first revision TKR that we have done. The primary TKR was done elsewhere. Then we have done the first revision TKR also. That was actually her sister. That was just incidental, and she's actually doing good. I respond over you to sir.
The question that you asked about how does it compare with total hip replacements? In terms of technology, robotic hip replacements are being done elsewhere, but we haven't got to that stage yet here. And the metallurgy and all the rest of it is almost the same. The wearing out, or what Nitin said, the wear rate, it's different for the hip because it's like a pestle and mortar. Whereas the knee, there is a lot of gliding and sliding. So there is delamination that we see more often in the knee, whereas in the hip, it's a true grinding down of the soft part, that is the plastic. But the longevity, we only reached 10 years, so our own experience is not that they're worn out, but it is thought to be maybe better than 20 years. Having said that, I remember one of my patients 40 years ago. Within 2.5 years, he wore out his entire plastic and he was walking metal on metal. This is a chap who was something to do with newspapers, and he came from Chhattisgarh, or what was it at that time? He walked and he wore it out totally, and he came with a grating. It was metal on metal. So yeah, it depends on how one uses it.
Since this was a topic of knees, I just want to mention that if it was arthroplasty, it was not October, but it was June, because the first arthroplasty that we have done is actually a total hip replacement that we have done in June 2015. And that was actually bilateral. Initially, we've done a one hip first, and then sequentially followed by a second hip a couple of months later. So that was the first arthroplasty that we have done, and the patient is still doing good. And I've in fact visited their homes and gone for the children's wedding, and although they're still in touch with me.
Recently, we had a patient with the septic arthritis in the medical ward who underwent the TCAR some near about 8 to 10 years back. And the patient has been taking antibiotics parenteral, including amikacin, continuously for the last 6 years. Some of you might have seen the patients, and finally the patient succumbed to death. Can you comment about that case?
Is it our patient or?
No, it was done outside.
So most probably the problem with giving antibiotics initially to the patients with replacement or an implant in situ is we will not be able to find the exact cause of the problem. So in here, what we do is we take cultures, blood cultures, the knee cultures, everything, and then only we'll start a course of antibiotics. So if the patient is coming to us from outside, okay, so what we do is we stop the antibiotics, we wait for about 2 to 3 weeks time, and then take a culture. So if the implant is infected, it has to come out. There's no way that you can treat the infection with an antibiotic, because the implant is not a vascular structure. So biofilm is formed, it will not be degraded with the help of an antibiotic. So we will have to take it out, wait, put a spacer which is having an antibiotic, wait for about 6 to 8 weeks time, give antibiotics if you happen to identify the organism. Then once the infection, everything is subsided, probably you have to go for a revision knee replacement. So most probably the case that you are talking about will be going to each surgeon. The patient would not be going back to the same surgeon. That is the most problem that we encounter. They'll go to one surgeon, not subsiding, go to the next person, go to the next person, it'll keep on going. So it's better that you go to the same surgeon who done the surgery, who will take care of the patients much better. So there will be we have a protocol for that, so we follow this protocol here.
If there are no more questions, we will wind up the quest for today. Thank you, Nitin, for taking us through this remarkable journey and the milestones achieved. We'll see you for the next quest next Thursday at 8 o'clock. Thank you.